We are now happy to turn to Dr. Yogeb קיויתי. Dr. קיויתי is a clinical psychologist and a senior lecturer at the clinical psychology program in Bar-Ilan University. His clinical and research interests lie in the understanding of the nature and treatment of borderline personality disorder. Before joining Bar-Ilan University, Dr. קיויתי was a Fulbright postdoctoral fellow at Penn State University with Professor Kenneth Levi, studying mechanisms of change in transference-focused psychotherapy for borderline personality disorder. He is also the recipient of the 2018 SPR Emerging Scholar Award. Dr. קיויתי, you're welcome.
Thank you. Hi, everybody. Thank you, Dana, for organizing this. It's really exciting that there's like a panel on BPD. I think it's very timely, very important. So I'm going to talk today about TFP, transference-focused psychotherapy. In the 15 minutes that I have, I'm going to try to cover both what TFP is, whether it works or not, talk about a little bit about the theory and the rationale, the techniques underlying TFP, and then throughout the talk, and more so towards the end, I'm going to try to talk about the promise and potential for people working in the community, and a few future directions. TFP is a psychodynamic psychotherapy for BPD, actually for various different disorders, personality disorders, but mostly BPD. The format is outpatient, twice weekly psychotherapy in individual administration. I will not go into the details of the evidence supporting TFP. There have been now 3 randomized trials and 2 or 3 open trials showing effectiveness of TFP, and it's now recognized as an empirically supported treatment by the APA, the NICE guidelines in the UK, and the Cochrane Review. In terms of the theory, TFP is based on Kernberg's object relation theory of BPD, where we conceptualize BPD as a disorder of identity, which means pretty much impairments in internal representations of self and others, what we call object relations in the TFP model. And the goal is to arrive at a more integrated identity with more mature internal representations, and I'll say more about that now. So what we mean when we say impairments in internal representation of self and other is that essentially we all have some form of schemas or representations of what we are and what others are. And when those representations are healthy, we really talk about more realistic representations, so that they correspond more with what the person really is or what their behavior really is. But in more primitive or pathological representation, what we see is more about distortion or biased representation of self, more towards all bad or all good. In healthy representation, we talk about integration, both positive and negative aspects of the person are consciously experienced at the same time, whereas in pathological representations, we see more of a split or polarized representation, so only the positive aspects are experienced at a single moment, and then in another moment the negative aspects are experienced. Another characteristic of pathological representations are indifferentiation of representation, which really means that people are experienced the same way. So, for example, you can see this when people talk about other people in very general terms. So everybody hates me, everybody's successful and I'm not. So that's kind of a very good indication of lack of differentiation. And then the last aspect, which is probably the most important when we talk about BPD, is stability of representations. So, and that kind of manifests itself in 2 different aspects. One is what we call oscillations in the dyad. So this corresponds to what we traditionally mean by split. So with this aspect, what is in conscious awareness is only one aspect of the person and the other, either the bad or the good. So one moment the self and the other are experienced as good, or it's bad in this case. And then if something happens, so for example, the person thinks about himself as a victim and the other is a neglectful other. If the person receives support, all of a sudden all the victimhood is kind of being forgotten, and what is brought into awareness is only the good aspects. So that's the more traditional way of thinking about instability of representations. Another form of instability, which is maybe one of the most central contributions of Otto Kernberg is what we call role reversal. So here, the same aspects, either the good or bad, stay in consciousness, but what changes is the role that the self or the other assume. So if, for example, one experiences himself as a victim and the other is a persecutor or someone who is neglectful, then something might happen, and then the self will be experienced as aggressive, and the other will be perceived as a victim. So just to give an example, I had a client in the US that came in with troubles in forming relationships. She found it hard to trust other people. She found them to be disappointing with her, not really worthy of trust. And then I would, at the beginning of the session, I would go pick her up from the waiting room, and we would walk together to the treatment, to the therapy room. And usually what I would do with clients, I would lead the way and then show them where the room is and maybe open the door for them. But in her case, she insisted on knowing what the room number is, and she would lead the way, just let me be behind her, and she would open the door, and then I would go in. And then immediately as she sat in, she was supposed to start the session, as we usually do in TFP, and then she would complain about me kind of leaving her, not really leading her. She would feel that she's being left alone, and I'm withholding from her some sort of knowledge that I have and not giving her. So you can see how she switches between feeling herself as vulnerable, and seeing me as vulnerable and her as very strong. She's feeling herself as vulnerable, and I was kind of withholding and very strong, not giving her what she needs. So this is the kind of the other type of vacillation that we talk about, and this is what makes, in my opinion, this is what makes BPD clients very challenging to work with, because just when you think that you figured out something, something changes, and then they switch between worlds, and then everything that you think you know kind of changes, and you need to figure out and then recalibrate. So really what we do in therapy, in TFP, is really geared toward creating some integration and having the patient be more stable, more integrated and more stable in their representations. And the way we do it is by using 3 different classes of interventions. The first one is what we call clarification, which really is about being curious about the patient's or the client's subjective experience, asking questions, trying to really understand what's going on in their subjective experience. And this really activates those dyads that we just talked about and help us make them more accessible for treatment. And then the other type of intervention is called confrontation. It's not really a very good term for it. Maybe empathic confrontation would be a better one. Really what we talk about is being very tactful and collaborative in bringing into awareness of the patient some contradictory aspects of their experience. So going back to that client that I just talked about, one time she comes in, talks about a guy that she's dating. It seemed to be going well, but she feels that he's much more interested in her than she is in him. And she talks about it as a very painful experience, how she's kind of sad that she can't really reciprocate the love, and she cannot feel the same for him that he feels for her. But then she's talking about this, and it's good that it's painful for her. She also has a half smile on her face. And then I was able to kind of bring that into awareness. I mean, I can tell her, okay, I mean, I see that it's very painful for you, but I'm not sure that you're aware of it. As you're saying this, you're also kind of half smiling. And then she smiles even more. She said, yeah, I noticed that too. And then we could talk about that and how there's a part of her that really feels, takes some pleasure in being the stronger person here, that doesn't really let herself commit to that person, to the guy, what he needs her more than she does. So that's what I mean by confrontation. And then the last piece is what we call interpretation. And here we try to really, again, collaboratively try to get what are the presumed causes for those discrepancies that we just found out. What is the motivation for keeping them separate? What is the motivation for keeping those representations not integrated? So again, going back to the client, we could talk about her desire to be in a relationship that she's being taken care of, but at the same time, her fear of being let down is something that leads a lot of the dynamics that she's experiencing and not being able to commit to other people. So these are the 3 different interventions with the goal of reaching integration. And when that happens successfully and repeatedly over time, we might expect some more consistency in the experience of the world. Again, these people come in with a very chaotic experience of life, so that helps it make more sense. and then they're more able to form satisfying relationships and accomplish life goals. The treatment itself, moving to the structure, is consisted of 3 different phases: assessment, and then establishment of a treatment frame, which really includes 3 different sub-steps: providing feedback, goal setting, and discussing roles and responsibilities. And then the last part is active treatment, which is the bulk of the treatment. I'm not going into too much detail with the first 2 phases. Perhaps I would just highlight that TFP provides very useful tools for assessment. There's a semi-structured interview called the structural interview, which I find very useful in forming very quick and very not very time-consuming formulations for the person dynamics, which are then very easy to discuss with the patient. And then we also provide them feedback about the disorder, about what we see as their dynamics, what leads them to treatment. We ask for 5 minutes. Okay. We ask for their feedback, and we try to arrive at a shared understanding. But again, I can't really discuss this in full. I would just say that some of the take-homes here are that diagnosis can be shared with people with BPD, and it's actually part of the treatment. Setting goals is not taboo, even in transfer-focused psychotherapy or in dynamic psychotherapies. And we really try to be very transparent about how the therapy works. And then moving on to the active treatment, the general approach of the therapist is one of technical neutrality. And what we mean by that is that we do not take sides with the patient's conflict. We don't really take a stance. We try to be very open, very accepting of their conflicts, and maybe tolerate and explore their own projections. This is not to say that we're not warm, not empathic, quite the opposite actually. We really think that being warm and empathic is key, but we try not to take sides. The TFP is relatively an active treatment compared to traditional dynamic treatments. The therapist is really free to ask questions, to bring up things to consider. We don't really wait for the patient to bring up things. We actively do that. And we focus on the object relations and how they vacillate in the here and now. And we really try to attend to 3 different forms of communication: what the patient is telling us, what the patient is telling us non-verbally, their non-verbal behavior, and we also attend to our own counter-transference and what we can learn about that, just by our own experience. And as I said before, what we really do most of the time, we use clarifications, confrontations, and interpretations. And one thing that TFP is very useful for is that it sets very clear priorities of what you do in session. So first you follow the dominant affect. What is the patient really experiencing? Because this is very close to their consciousness and really easy as a starting point. And then we attend to the transference. And then we have a very clear set of priorities of what we attend to. First we attend to threats and the safety of the patient or the therapist, threat to the safety of the treatment, and so on and so forth. So some of the take-homes here is that a non-judgmental stance is really helpful here. It actually reduces resistance. And naming the actors or naming or explicating the dyads really makes a lot of sense for the patient. It makes their experience much more meaningful. It makes more sense to them. And attending to the priorities makes sense for the therapist, because these patients come in with crisis after crisis. It's really hard to remain in control over things. So adhering to those priorities really makes sense to the therapist. So just a quick summary, TFP is effective, and I think it holds a lot of promise for people in the community, both as a full package, but not necessarily. I think it's consistent with the structure and the constraints of treatment in the public sector. It only includes an individual therapy component and not a group component, which sometimes might be logistically hard to put together. It doesn't require phone consultations, for example, outside of work. And it's based on the psychodynamic training, which is still the prevalent model of training here in Israel. And as I said before, I think it's useful even if you're not implementing a full TFP program, and which is something that I call like the TFP toolbox. For example, naming the actors, attending to role reversals, sharing diagnosis and treatment rationale, goal setting in a psychodynamic frame, and also assuming a very non-judgmental stance and following or adhering to treatment priorities. So some future directions, and very, very briefly, We're now working on having more resources in Hebrew available. If you Google TFP in Hebrew, you'll see a YouTube talk, a brief article in the Hebrew Psychology portal, and a Wikipedia entry, and there's more to come. This May, we're going to have a 2-day workshop. Fortunately, we were able to bring Dr. Kernberg and Dr. Yeomans to a 2-day workshop in Bar Ilan, hosted by the Psychological Clinic. And we are also working on dissemination in Israel more broadly. This is a joint effort with Boaz and Gestalter, who is a clinical psychologist in the community. And if you're interested, contact me for additional opportunities, both in terms of research and practice. I guess that's it.